Also, until you get a patient in an upright position, one of the causes of urge incontinence can be bladder prolapse. So the bladder can prolapse down into the vagina or even out of the vagina like this. So the bladder, all of the urine is prolapsing down, and this is a cause potentially of obstruction to the urethra. That prolapse of the bladder needs to be pushed back surgically. There's no medication that's going to fix that problem. And so that's the other thing, is that there are medications, exercises, a whole range of non-surgical treatments, and knowing when to apply those problems, particularly if they're severe and not responding to conservative treatment, it's important to define what the problem is, because it may still be absolutely reversible, curable. So getting the prolapse back into position, so the bladder restored back above the pelvic floor, and then supporting that with a sling, so that gives you a upward force so as to prevent the bladder from going back down into its prior position. So we repair it from below, push it up, and then there is definitely a tendency for that type of operation to recur. There's good evidence now that if you do a preventative sling, that stops the bladder prolapse from recurring, or it's associated with a much lower incidence. And that's particularly important if the urethra is coming right down as well. And sometimes what happens is patients got a problem with stress incontinence, or their bladder neck's open, and you can see that with fluoroscopy. The prolapse is down, so it's masking. When the patient coughs, the pressure is transmitted into this prolapsed organ. You push that back surgically. If you do nothing around the urethra, you may now have severe incontinence for the first time, which was potentially detectable if done accurate testing prior to the surgery. This is a model of the clitoris, so that tissue, the pink and blue, shows you the relationship of that organ to the urethra. One of the strategies we use for treating stress incontinence, where patients have had repeated failure from previous operations, is to pass a little, like a steel instrument, into the interval between that blue structure and the pink one, that goes up to the bladder neck, which we've been looking at, and a balloon is placed on either side of the bladder neck. On the other side, so on the top side, if you like, you can see the bladder through there. So on the inside of the pelvis, the balloons reach a position on either side of the urethra, so that it compresses the urethra and stops it leaking in that situation where the bladder neck's open. I think we've still got a fair way to go in terms of development of good databases about what are the best techniques for preserving structures. Having said that, compared to 20 years ago, we're a long way further down the track, and people have at least looked at it, and it is part of any multi-national, multi-centre study, an intention by the Incontinence Society to collect sexual function measures as well as urinary function measures. So what we want to do is correct a problem and not cause any unintended effects, broadly speaking. And for both obstruction and incontinence problems, and a number of causes of infection as well in both men and women, often that's achievable.